My name is Yahya Isawi. I'm a consultant neonatologist, and I love research, and I'm a research advocate. So this is, I have a question. Okay, so this is, we'll start a series of presentation about neonatology, and I thought the best start is to start with research. Because I think practicing neonatology without research is a little bit handicapped. So to kick off this talk about reviewing neonatology, I will give 13 or up to 14 presentations and sessions about doing research. And I think the pillar of the research, to have a good foundation of research, you really need to ask a correct question, because a correct question means a correct study type and probably a good protocol and so on. My objective in this talk is to describe what is the meaning of the anthem PECOT, and what are the types of research questions, and how to practice the sequence of generating a research question. And hopefully at the end, I'll give you some tips and probably we'll do some practice. So the research question has three pillars, three components to start. The first one is the anthem, the abbreviation PECOT. The second one is the target, what you want to do, what you are targeting, what exactly your subjects of the questions. And the third pillar is evidence-based practice. So let's start with the meaning of PECOT. So PECOT, for P meaning either population or patient, and the I means either indicator or intervention, and C means comparison or control, and O is the outcome, and finally T indicating either the time of the study, or sometimes if there is no time, or there is a specific time, then it indicates the type of the study. So if we do a table and look what is the target, like what is the aim or what you are targeting with your presentation or the research, we can say the target is either an interventional, or you want to see a diagnostic tool, or you're looking for the etiology, or you want to prevent the disease, or you want to talk with your patient and tell him what is the prognosis and what is the prediction of your problem. Or sometimes you want to ask the quality of life that the disease affects the patient. And sometimes you're looking just for therapeutic. So if we put the abbreviation PECOT with our target, and let's start with an intervention and ask the question on this sequence. So the question in intervention will be in a given population or patient, how does the intervention or the indicator compared to the comparison or the control affect the outcome? Somebody is asking question? Okay, Hiba is coming. Okay. So what are, compared to the comparison or the control, how it affects the outcome in a given interval or time, or in a given interval or in a given study type. So we have more participants. Let's admit them. Okay. So let's do the questions in reality, because sometimes the question can be asked in a different way. And this way is, in a population or a patient, what is the effect of an indicator or an intervention on the outcome compared to the comparison or the control within the study type or the time. So let's ask a real question depending on this frame. So for example, in premature babies less than 29 weeks with RDS. So this is our population, very specific. Now remember, the more specific the question is, the less sample size you want, and more precise. The wider the question, the wider your population, then probably you need more sample size. And therefore, the more specific your question, the better will be the, less the sample size, more control of the outcome, and so on. So, in premature babies less than 29 weeks with RTS, we're very specific. We are looking for premature babies or less than 29 weeks, and they have RDS. So this is our population. How is surfactant administration? So this is not an indicator. It's actually an interventional study. So we're giving surfactant. Compared to CPAP. So this is our comparison. There is no control here. How that surfactant administration as an intervention compared to the CPAP affects the respiratory support. So our outcome is the respiratory support. Or our outcome is the duration of the respiratory support. During what? During hospital stay. So that's our time. So let's repeat it. In premature babies less than 29 weeks with RDS, how the surfactant administration compared to CPAP, of course without surfactant, affect the duration of respiratory support during hospital stay. Which means the questions of an intervention is targeting the treatment of an illness or a disability. So let's move to another question. Diagnosis, same frame. So the diagnosis can be, of course, one, can be more than one. So are or is an intervention or indicator more accurate in diagnosing the population compared to the comparison for the outcome? And you can see here there is no time because it implies the study time. We can ask it in another way. In a population, are or is an intervention, which is an intervention, which is here the diagnostic test, compared to the comparisons, affect more accurate in diagnosing the outcome. So let's ask a real question. The real question is the NTS or neonatal newborn screening test done at 2 weeks old infant? So the intervention or the diagnostic test is the newborn screening done at 2 weeks of age of a premature baby. That's our population. More accurate in diagnosing or in diagnosis of inborn error of metabolism. That's our outcome, compared to a newborn screening test done at 24 hours of age. So that's our comparison. The time here, as I said earlier, implies the 2 weeks and the 24 weeks of the age. So I will gonna repeat the question because it will make it more fun. Is the newborn screening test done at 2 weeks old infant more accurate in diagnosing inborn error of metabolism compared to the newborn screening test done at 24 hours of age? Let's ask another diagnostic, or let's frame another diagnostic research question. In late premature boys with suspected sepsis, so very specific population, are serial CRP, so that's our indicators or the intervention. Compare, of course there is no intervention, so that's an indicator. Compare with one initial CRP, so the indicators is serial and the comparison is 1 CRP. More accurate in diagnosing early neonatal sepsis. So our outcome is early neonatal sepsis. And the time implies here on the type of the study, which is, I won't say interventional, but I would say indicator. So the question or the research questions in diagnosis is addressing an act or process to identify or sometimes determine the nature or the cause of a disease or injury through an evaluation process. So let's do a question in etiology. And in etiology, if we follow the PECOT acronyms, the question will be, are population who have the intervention or the indicator at increased or decreased risk of an outcome compared with the population with or without the comparison over a period of time? Or we can ask in another way, are population who have the intervention or the indicator compared to those without compared to those without the intervention, which is the comparison, are at increased risk of the outcome over a period of time? Let us make it a real question. So, are fetuses, so our population are the fetuses, who have parents born prematurely, so the intervention or the indicators are the parent of that fetus who were born prematurely, at increased risk of prematurity. So, if the fetus will be born premature because their parents were premature, so our fetuses, which is our population, who have a parent born prematurely, and that's the indicator, at increased risk of prematurity, that's our outcome. Compared to infants, or fetuses, sorry, whom parents born at term during the pregnancy, which is our time. Another way to ask question. Are 11 to 30 days old premature babies, so that's our population, who are on EBM, that's our intervention, compared to those without EBM, that's our comparison, at increased risk of necrotizing enterocolitis, that's our outcome, during first week after starting feeding, that's our time. So the question in etiology is addressing the cause or the origin of disease and the factor that produces or predisposes toward a certain disease or disorder. Now let's ask the same question for intervention. And the question would be as follows. For a population, does the use of intervention reduce the future risk of the outcome compared to those who is not receiving that intervention, which is the comparison? So the question, an example of the question. In labor room nurses, does a 5-minute scrub, so that's our population, that's our population. Sorry, some people are trying to enter. For a population, does the use of intervention reduce the risk of an outcome compared to other populations? So the question would be in labor room nurses doing 5-minute scrub. So the population is nurses in the labor room doing hand washing. Okay, what are the difference in the presence and the type of microbes? That's our outcome. The type and the presence of microbes found on the natural polished nail and nail bed. That's our indicator, which is the number and the types of the microbes on the nail and nail bed. Compare with those with artificial nails, which means they put an artificial nail and when they scrub their hand, they remove that artificial nail at the time of the surgery. So the question in prevention is on how to reduce a chance of disease by identifying or modifying risk factors, and how to diagnose the disease early by screening. Again, let's ask same question for prognosis or prediction. So the question would be, does the indicator or the intervention influence the outcome in patients who have the problem, that's our disease, over a period of time? Or we can ask it in a different way. In a population, how does the intervention compared to the comparison influence the outcome over a period of time? So a real example, does saturation telemonitoring, so our intervention or indicator, here I think it's indicator, not intervention, if we connect a monitor and we observe it or we monitor it remotely, does the monitoring the saturation remotely in newborn babies who is discharged from the unit at the age of 35 weeks corrected, so that's our population, improve apnea management, so outcome is apnea, within 6 months of hospital discharge, so that's our outcome. Another question, for premature babies less than 35 weeks corrected gestational age, so that's our population. How does the use of influenza vaccine, so that's our intervention, compare not receiving the vaccine, so that's our comparison, influence the risk of developing pneumonia during flu season, that's our time. And our outcome is the pneumonia. So the prevention question is addressing the prediction of the course of the disease. So two more targets. The first one is the quality of life or the meaning of life. So how do a population diagnosed with an intervention or a problem perceive the outcome during the study time? So for example, how do pregnant women, that's our population, diagnosed with possible delivery by an obstetrician, that's our intervention, perceive the reporting when the nurse or the midwife informing them that they will start prematurely? How they perceive that? These news of bad news of being starting premature labor. The time here is prior from the point of informing to the point of delivery. So the quality of life is a question addressing how we experience a phenomenon. And last target is the therapy. So the question in population, what is the effect of an intervention on the outcome compared to the comparison within the time, study time or study time? So what is the duration of recovery? That's our outcome. For patients with perforated neck, so that's our population, who were treated with primary peritoneal lavage, that's our intervention, as opposed or compared to Penrose insertion, that's our comparison, within the first 6 weeks of occurrence of neck. This is our outcome. So the question is, in therapy or in a therapy question is a question around how to select treatment, best treatment to offer to our patients that do more good than harm, and that's worth the effort and the cost of using them. So we've talked about the acronym PECOT, and we've talked about the targets. The third pillar of asking or generating a research question is the evidence-based practice. Now, evidence-based practice depends also on factors. The first one is the best research evidence. So to practice evidently, you need to have the evidence. And to have the evidence, you need to know how to research it, how to find it. In addition to that, you should have the clinical expertise. For example, I'm an hematologist. I want to ask a question in anesthesia. I can find the best evidence, but I will not able to ask or practice evidence-based because I have no experience. So it's not enough that you search the best evidence, but you need to have a clinical expertise. And that's not enough because you need to know your patient values. So, for example, you want to, give something from porcine to a Muslim person, or you want to give a blood transfusion to Jehovah's Witness people. So their values are different, so they affect the decision. Now, how to do these three pillars? You need first to ask questions, and then you need to align with somebody experienced before you start your evidence practice. And then from that experienced person, you need to acquire the knowledge. And then you need to appraise that knowledge. You need to know how to appraise it. And then you need to know how to apply it. So after you have the best research evidence and you have clinical expertise and you consider your patient values and preference, you need to ask questions. Without asking questions, you cannot. You need to doubt everything. And then you need to join somebody or a team or an institute with experience. You need to acquire the knowledge from them. And then you need to appraise their work. And then you apply this knowledge. And then at that point, you can practice the evidence. So now you have the PECOT, you have the target, and you have the evidence practice, and then you can ask your research question. Now, I'm going to unmute somebody if somebody wants to ask questions, and I want you to practice. So I'm going to ask you a question, and if nobody up to answer, I will answer. So the first question is, and the floor is open to everybody. If you want to answer it, I will unmute you. The question is, a doctor wants to select ibuprofen or paracetamol to treat a PDA in a premature baby less than 25 weeks. How you're going to ask the question? Anybody to want to answer? Anybody? You can wave. You can text me if you want to practice. Okay, no volunteer. So I'm going to answer the question. Anybody want to answer? You can text me. You can unmute yourself and ask. No?
Yes,
Yeah, go ahead. Answer the question.
So it is first the question. It's intervention.
It's
right?
intervention. Yes.
Ibuprofen. No, sorry. It's
so
the target is.
Let's start with PECOT. Let's start with PECOT. What is P indicating here?
The population.
Where are the what?
Population is the premature baby with VDA.
Less than?
Less than 27 weeks.
Correct. So in premature babies less than 27 weeks with a PDA. Okay? So this is our population. Yeah. Okay, continue. So second is the I. What is the I? Ibuprofen.
Ibuprofen.
Ibuprofen. What is the C?
C compared to paracetamol.
Correct. So in premature babies less than 27 weeks with PDA, does ibuprofen compared to paracetamol? So you answer the P, the I, the C, and what is the outcome?
Hospital
closure of the PDA. No, closure.
The
hospital. Right? The outcome is the closure of the PDA. Correct? Correct? Ibal, are you with me? So the outcome here is the closure of the PDA. What is the time here?
Yes. The time 16 versus 24 hours.
No, the time here, remember that we give because you should have an expertise of, so we give the ibuprofen over 3 days, while the paracetamol over 7 days or 5 days, correct?
Yeah.
So the question
Yes.
will be as follows. In premature babies with PDA, in premature babies less than 27 weeks with PDA, does ibuprofen compared to the paracetamol close the duct during the therapeutic period, which is in ibuprofen 3 days and in paracetamol 5 to 7 days. Isn't that right?
Yes, this is the time.
Okay, so you can mute yourself and then we'll go to second if somebody else wants to practice. The question is, in the second question, hospital want to decide 16 hours shift versus 24-hour shift. For interns, people or rotators, they call them in Iraq, the interns, and they want to study the safety point of the view. So any volunteer want to generate that research question? Any volunteer? You can unmute yourself.
Assalamu alaikum.
Alaikum assalam wa rahmatullah. Introduce yourself.
I'm Dr. Maher.
Dr. Maher. Let's go. So let's start with PECOT.
The population here is the intern.
First, what is the target?
The target is the safety.
So the target is the safety. So if the target is the well-being, okay, or the well-being or the experience or the emotion or the safety of the population. So that's the target. Okay.
Yes.
Okay. What is the population?
The population is the intern who is working in the hospital.
The population is the intern. Great.
The intern, yes.
What is the intervention?
Intervention is 16 hours on call versus comparison to 24-hour calls.
Correct. And the outcome?
The outcome is
you have to select the outcome here. So we need to know, is 16 hours safe or 24 hours safe? So we need an outcome. So I would select the outcome. For example, making orders or the number of errors at the end of the shift. Or, for example, the number of speeding tickets by driving home, or the number of car accidents driving home, or the number of conflicts between the intern and, for example, the nurses, or the conflict between the intern and the patient. So our outcome is from that safety point. So you can select the medical error the intern they do at the end, or, for example, the accident that happen after they go home while driving, or the speeding ticket, or traffic violation, or, any outcome. And what is the duration?
The duration
is the internship period.
Yes.
Okay? So let's ask the question. Now we have all the acronym, the PECOT, we know the target, okay? And so let's ask the question. Do you want me to formulate it, or you can formulate it yourself?
Is the 16 hours.
Okay. Compared to 24 hours.
Compared to 24-hour calls for the intern.
Okay. During their internship period.
Yeah. For the intern. Is it safer?
Not safer. No, we need to ask a specific question. We said, what is the safety point of view? Either making, you said, conflict with the nurses or patients, making medical error, or making a speeding ticket, right?
Okay. Yeah.
So let's repeat it.
Okay. Is the 16 hours on call compared to 24-hour calls for the intern during the rotation?
Causes,
for the medical error.
At the end of the shift.
Yes, at the end of the shift.
Correct. So I will write it in a way. Does 16 hours versus 24 hours for intern during their internship cause more traffic violence during their driving at the end of the shift to home? Or again, does 16 hours compared to 24-hour shifts for intern during internship cause more patient conflict with them? And so on. You can ask the question in any way and in any way you want. So let's go to the third example, and I don't know if there is a volunteer. The ministry wants to know if the nursing triage. So the ministry wants to do a nursing triage, and the ministry wants to know if that triaging can it reduce the waiting time prior from registration to entering to the doctor. So they want to know if a triaging you can mute yourself, Hisham, because we may ask another person to ask questions. So the ministry wants to know. The ministry wants to implement nursing triage, and they want to know whether that will reduce the waiting time prior the patient entering to the doctor at the emergency department. So any volunteer to ask the question? Any volunteer? Other than, of course, Nibal and John. Any volunteer? No? So I will answer questions. So the target here is intervention, because we're doing triaging. Hello? Anybody? No. So the target here, the tribe is intervention. The population is triaging nurse, or the nurses. No. The population here, the patient, registered at the emergency and want to go to the doctor at the emergency department, the emergency physician. The intervention is nurse triaging. The outcome is the waiting time. And the period is during the patient's presence in the hospital. So the question would be like this. In patients registered in the emergency department, does nurse triaging reduce the waiting time from registration to entering the doctor room during their hospital during their hospital stay? And we can ask it in a different way. Of course, there are other ways to ask the question. So I am done.